This is Dr. Tom Dombrowski uh, giving Chapter 11 of the Weber and Kelly lectures. So first off, we need to know why we assess culture. I mean, it's interesting, but there's a lot of things that might be interesting about the patient that we don't necessarily assess. So why should we even assess culture? Uh, we don't normally assess people's fashion sense or their taste in music or any number of things. But culture affects, one of the things culture affects is people's concepts of what illness is, people's concepts of when it's appropriate to seek a treatment, what treatments are going to be effective, and also what treatments are going to be acceptable to people, and who it affects who they would turn to for help. Like in most cultures, why people turn to physicians, but they may also turn to other types of healers, or they may not turn to physicians. They may, and based on culture too, they may or may not accept the help of the nurse. So culture definitely affects all the barriers to seeking care, and it's easy to kind of externalize this and see this in terms of other people and think of, somebody from I don't know where, from rural Central America who doesn't want to seek care because she believes that people that go to the hospitals where you go to die. That was her experience growing up, and even though she's living in the US now, in her mind, when you go to the hospital, that's where you go to die. And so it's easy for us to see that in cases like her. But what are the barriers you face to seeking care? Maybe, oh, well, they're going to ask me to undress, and I just can't stand for them to see how fat I am. I try to hide this, but I just can't stand to see them to see how fat I am. Or, well, I don't know how much they're going to charge me. My insurance is bad. The co-pays are really excessive. I don't know how much they're going to charge me. Or, oh, the doctor's going to just put me through all kinds of painful procedures. So you also have barriers to seeking care, which you may or may not overcome when some illness occurs. And your patients are just like you. They have various barriers to seeking care, but based on their culture, those barriers may either be the same ones that you have, or they may be different barriers. Some of the dimensions of culture that we'll be looking at, one big thing is communication patterns, and not only in how do you communicate, like what language, but who communicates with whom, in what way, formal and informal communication, and all that sort of thing. uh, Rituals and behaviors, uh, and the approach to various life events such as birth, pregnancy, death, and all the things that surround those. Like uh, and that certainly changes over time. Like when I was a boy, why, it was unheard of for husbands to be in the delivery room. That would have been, if a husband would have requested to be in the delivery room, everybody would have thought that was an extremely strange request, for one thing, and it probably would not have been allowed. It was something that just nobody would have even thought about it. And the idea of a home birth would have been probably been unacceptable too. Like people would have said, "Oh, that's just too dangerous. You can't possibly have a birth at home. That's what they do in third world countries, and that your baby's going to die, and it would be considered." It would be considered something foolish and abusive, and people would have and so now, of course, home births are acceptable and they're not dangerous. And I mean, they may be a little slightly more dangerous as far than hospital births, but not outlandishly so. Husbands and other family members are routinely allowed in delivery rooms. Um, so that's one example of something that in our own culture here in the United States that has changed dramatically over time, and similarly things in other cultures will also be changing. Like a lot of times we'll get our information about a culture or have our beliefs based on something from 20, 30 years ago that is now no longer the case in those other cultures, or so that's something to think of as well. And approach to events such as death too. How do you what do you do in the case of death? What kind of funeral type arrangements do you make? Who makes them? Is the body kept in a funeral home or in the house for the wake, or in some cases there are all kinds of different practices may be done around death too. And then another dimension of culture is that there are differences in disease susceptibility, like even just what diseases a person is at risk for may be influenced by their culture, both by their uh, ethnicity and their genetic background, but also by lifestyle practices and the situation of the community they live in. Even the diseases you may be exposed to will be different. Some of the things we'll be assessing would be family structure, uh, which can vary, and the family structure itself can vary, and the people's attitudes and relationships to each other. Also, spirituality and religion, which would be very different based on culture, and community, the sense of community, what you can rely on from your community, what your obligations are to your community, all those kind of things. So let's define some terms. Culture is a system of shared beliefs and behavior patterns that is mostly unconsciously learned. We learn it over time without being aware of it. And when we've had discussions of culture, I've had students say things like, well, I don't have any culture. I've lived all my life in Fort Worth. And it's sort of like being a fish in water and you're not aware that the water is there because it's always been there. I did not come to Fort Worth for the first time until I was probably about 25 years old. And believe me, it seemed like a very exotic place when I first came. Now, I've been here many years, and so I became acculturated, and it seems I'm the fish in the water now, but when I first came, it seemed like a very strange place, and I put my foot in my mouth quite a few times and said or did the wrong thing, and so and found all made so it's just And the same thing is true if you go, say, to Los Angeles. From Fort Worth, you've been in Fort Worth and you go to Los Angeles, and you will meet, someone that, well, I've been in Los Angeles all my life. I don't have a culture, that person would say, and you would say, oh, to me it's very strange here. Values. The values are learned beliefs about the culture is the beliefs and behavior patterns about reality, where values are a little more specific. There are judgments and beliefs about what are good and bad things. Like, so you have positive values and negative values. Like, for example, you may value friends and friends' opinion very highly, and at this point in your life you may not value your parents' opinions much at all. But say when you were a child, you probably valued your parents' opinions very highly and your friends' opinions somewhat, but not as highly as your parents' opinions. So that can change over time, and that also can change based on culture, whether how important your peer group is to you as opposed to your parents, or what your relationship with your parents should be like even as an adult, or other leaders, your attitude toward other leaders, community leaders, that kind of thing. Uh, what value is placed on education? What value is placed on health and health care? What value is placed on economic success? Those kind of things. Norms are similar, but they're more in the way of like standards or rules, almost rules. They're not quite rules, but for example, we have a norm that you uh, dress in a certain way at UT Arlington. If you came to class, just to a lecture class, wearing pajamas and slippers, we probably wouldn't kick you out of class, but people would look at you. You would be breaking a norm. It can be a little stronger if you came to lab in those pajamas and slippers, or to the clinical site. Why, then yes, we would send you home. So that would be a little bit stronger situation. But many other norms exist, and they're not always even spelled out. There might be a norm that if somebody asks you a question in a polite way, why you answer it and try to be helpful to them. But then maybe the norm is that if they ask you something highly personal, why then you're allowed to get somewhat offended, but you're probably not allowed to hit them unless it's extreme provocation or something. But the norm would probably not let you, our norms would probably not let you hit them for asking you something unless it was something extremely offensive. So all of these values, norms, cultural beliefs, all of these come together to make up a worldview. And a worldview is a shared perspective, a shared reality, if you will, based on all these beliefs and values that is sanctioned by a culture. And this implies there are other worldviews. So if we can imagine, say, a Native American who lived on a reservation and was very much in tune with traditional ways, that person may have a worldview where animals and trees and the earth itself and the rivers and all of these are alive, and they're part of a whole that is in intimate relation to her or him, where those of us that grew up in a city and with a Western kind of worldview have an attitude toward nature, that nature is apart from us and it's something that we should exploit and we should conquer and we should just abuse and subdue, and we don't need to be worried too much about the consequences of it, because our highest value is to make all the money we can, and uh, we aren't going to be too concerned about polluting or contaminating or those kind of things. So, whose worldview is true or right? Is our worldview that we're just separate from nature and nature is something to be conquered true? Or is a worldview that we're in this part intimately related to this living world around us that's in intimate relation? Is that a true worldview? I leave that for you to decide. There's probably many different possible worldviews that a person could have, and perhaps none of them are true and none of them are false. Perhaps they're all true and perhaps they're all false. Then another term, ethnocentrism. This is the perception that one's own worldview is superior to all others. And I think all of us, at least at some point in time, have been there. We've felt that our worldview was superior to all others. Maybe some of us do even now think that our worldview is superior to others. Some people, extreme ethnocentrism, you may not even be aware of other worldviews, that other worldviews exist. That's the person that has been in one place all her or his life, never really come into contact with too many other worldviews, or if they did, they just thought the person was wrong, or the other person was wrong, or primitive, or if they did, and so they have limited experience of other worldviews, and so that could be one reason for ethnocentrism. But then there are other people that are well aware of all kinds of other worldviews, but they think their own worldview is just the superior one, that is the right one, and all other worldviews are wrong. Then another term, stereotyping. This one is you become aware of other worldviews and other cultures, but you start thinking that all the members of the culture hold the same belief or they behave in the same way, so that you think, well, oh, let's see, she's from Mexico, so I guess she will love mariachi music, she'll eat lots of chili, and she won't speak English very well. And you just have that. That would be that would be a stereotyped attitude where and then if you find that the person you have stereotyped in that way, you find that they're not that way, or that they don't meet those, well, she's the exception, but everybody else, the next one I meet, will just conform to that stereotype. Then ethnicity is identifying with your ethnicity is a group that you identify with, that it can either be, it's socially or culturally constructed. It may have a genetic basis, as far as, or it may be a geographic group. So there may be maybe some ethnicities would not necessarily be genetically related, but would be geographically. So you could say for your ethnicity maybe could be Hispanic, where Hispanics can be of any race, for example, or your ethnicity could be I don't know, European, and it could be various things. Race is a socially constructed concept that's meaningful for the larger group. It's extremely important in America. We focus on race to an extent that probably few other countries do. Just a extremely important thing, that it's almost the first thing we notice before we notice your gender or your social status or anything else. We notice your race and we pigeonhole you in that race from the beginning. But it's a socially constructed concept in that, for example, we socially construct Barack Obama as being a black president, but his ancestry was half black and half white, and possibly some, but yeah. So in our social construction of race, if you're identifiably black at all, well, you're black, or if you're identifiably Asian at all, you're Asian. That we have these racial constructs that are socially constructed, and you could take the DNA and maybe trace out some of these racial characteristics, but it's not really based on DNA or on any scientific concept at all. Minority means that a group with less members. So if you have a city where 70% are black in the city, 10% are Hispanic, and 20% are Caucasian, why then Hispanic and Caucasian would be minorities in that city. But it also has connotations of less prestige, where even though the meaning of it is that it's a group with less numbers, but when we talk about minority, a minority, why it kind of, the undercurrent there is that it's a group with less prestige. In immigration, immigrants are people who are not native born. And this can also have connotations where, particularly in the last few years, where there's been a lot of talk about the danger of immigrants to American society, or how this sort of thing, a lot of people have demonized immigrants. Both legal and illegal immigrants have been demonized, and so when we talk about calling somebody an immigrant, I mean it just means that they were not born in that country or that place, but it's almost a term that an insult, and it's not really, but it can be taken that way. So as nurses, we have standards on the hospital. There are standards for culturally and linguistically appropriate care. And these are not, it's not that just out of the goodness of your heart you're going to give culturally and linguistically appropriate care. This is something you are obligated to do, that based on government standards, and the hospital is obligated to provide culturally and linguistically appropriate care. So if you're a nurse that maybe does not like immigrants, and you're in the hospital and you're that lady in 220, oh, she thinks she's just entitled to translation services, and the hospital's being so good to provide her with free translators, and she's not even grateful for it. Well, no, that is a government mandate. We have to, as healthcare providers, we are required to provide culturally and linguistically appropriate care. So it's not something that we're doing out of the goodness of our hearts. It's that patient's right, and whether she's immigrant or a citizen or not a citizen, that does not matter. She is entitled to that kind of culture competent care. So there are 12. I can't remember if it's 12. I can't remember how many standards there are. I kind of summarized because some of the standards are a little repetitive, so I summarized them. And each patient has a right to, the basic thing is they have a right to effective, understandable, and respectful care. So that means that if they can't, if there's a language barrier, why the obligation is on us to somehow bridge that language barrier and provide the information that the person needs in a way that's understandable to her or to him. So, and that would apply to people with disabilities as well as people from other countries. So if we have someone with a hearing loss, we're required to get a sign language interpreter or provide the information in written form or in some way communicate it in a way that they can understand. Another standard is that the staff and leadership are supposed to be diverse and to be reflective of the community. Now that one, I mean, that one is not something you can't necessarily accomplish from night to day. For example, let's say that due to some war somewhere, we admit a group of refugees to Tarrant County, and these refugees speak a different language, such as, I don't know, let's say they speak Italian, just to pull language out of the hat, they speak Italian. So we can probably arrange for translation fairly quickly. We can get translations and get literature printed and all that sort of thing. But we have these refugees who recently came, and getting our staff and leadership in the hospital reflective of that community is not going to happen from day to night. It probably would take years. That would be a matter of years, but the hospital has to show that they're making good faith efforts in that regard toward diversifying their staff and leadership. Then another one, ongoing staff training and delivery of culturally and linguistically appropriate care. So that means that the hospital has to offer, they're required to offer training, ongoing training in all sorts of things. Like they have to give training in disasters, external disasters, fires, the HIPAA privacy law, all sorts of things. So that's another thing that they have to provide, and they have to be able to show that they provided this training for their staff. And that becomes important when, say, there's a complaint made. I don't think, probably nobody's going to look at that too much. Well, they'd look at it when they do the Joint Commission reviews of the hospital and stuff, but when they would really look at that would be like if, say, a member of the community was treated in an inappropriate way by one of the nurses, say, or by one of the hospital people. Well, then in the investigation that's following, probably one of the first things that they're going to ask the managers is, oh, what training do you offer your staff in delivery of culturally and linguistically appropriate care. And then the managers had better be able to show that they've been offering some sort of training, because otherwise the manager will also be in trouble, as not just the employee that did the was insensitive or whatever, but also the manager could be in trouble then. And this is something to think about, because some of you guys are probably going to be future managers. You maybe not right away, or right, need a few years, but somewhere down the line you're going to be a manager, maybe. Another thing, hospitals are required to offer free language assistance services. Usually the cheapest way to do that is by telephone services, particularly since, like, uh, there are really literally hundreds of different languages that might be called on to be used, and we can probably arrange to have translators in person for Spanish and Vietnamese, but it would not be practical to have for each hospital to have a translator that's competent in all the different possible languages that they might have. And then you also have to ensure the competence of translators. One of the things there is you don't use family members, especially not children of the patient. Why? Well, for one thing, HIPAA. For another thing, the family may translate according to their convenience. Family may misunderstand some of the medical terms. They may not be very competent at translating. They know the language, but they may not be very competent about explaining things and translating the meaning. So that's an issue. And in the case of using young children, why, it totally screws up the dynamics of the family dynamics when the adults are depending on the children to negotiate their way. And also, children may have poor judgment. They may misunderstand things, and they may sometimes be manipulative to get their own way, and so all kinds of bad things can happen when you use family members. Another issue might be if you have a wife that's in a culture where the men are very dominant and the husband is just sticking there, and he won't if he speaks English and as well as the language, and he'll translate. Well, you can imagine that he may translate things very much to his convenience and the way he wants things to turn out. So you want to get a professional translator. Another standard of care, meaning that this is something we're held up to: ongoing data collection about culture and language of our patients, as well as the surrounding community. So maybe your hospital is a really expensive hospital that you have to have insurance to get in, and so your patients are going to be of certain languages and cultures, and the surrounding community has a different pattern. So your hospital is required to collect data about both about your own patients and the surrounding community. Also, there's another standard that requires that you have community partnerships between the healthcare organization and the leaders of different community groups. So that, say, if you have this group of refugees that's living in your community, why, your hospital should be reaching out and trying to form community partnerships with leaders in that community to try to better serve that community. And kind of going with this, you should have conflict resolution mechanisms in place. when patients complain about poor care, you need to have some sort of mechanism to hear their complaints effectively and look into those complaints. And also, if people have conflicts with whether it's with a physician, with a nurse, with whoever, or if the nurse has conflicts, because nurses come from different cultures too. We have some nurses that are recent immigrants from other countries, and they may have conflicts with other healthcare professionals or with the patients based on they may enter into a conflict from that point of view too. And then public reports. The hospital should make public reports about their implementation of the standards. Now, you would probably have to look long and hard to find these public reports, but they're somewhere, somewhere that's supposedly public. So now turning to the idea of cultural competence, Campina Bacote has a model for cultural competence that's widely used, and it uses the acronym ASKED, ASKED. And so the idea is cultural awareness, and that means that you start to break out of that ethnocentrism, that you become aware that there are other cultures and aware of the cultures around you. Cultural skill, meaning that you begin to navigate through the different cultures like you. And people do this unconsciously, perhaps, after they become aware of different cultures, like they may become, say, maybe their own culture, maybe your culture is really informal and you call everybody by their first name, and even, you know, even the boss, you call him by his first name and all that in your culture, but you are maybe not even aware on a conscious level, but there's another culture living in your community where people are formal and they address each other Mr. and Mrs. and all this. And when you're having conversations with those people without even realizing it, you follow those cultural patterns. That would be one example of cultural skill. And of course there are many more situations like that come up in the hospital all the time. And so when you become skilled at addressing those factors, why then that's cultural skill. Cultural knowledge consists not only of your knowledge of the beliefs, patterns of behavior, but also your knowledge of the diseases that people from other cultures are at risk for. So that's knowledge of the culture itself, as well as the impacts on health. Cultural encounters are whenever you have dealings with people from the other culture. And these could be in the hospital, but they could also be outside. They could be, anywhere, whether it be in commercial dealings, social dealings, public events that you go to, any sort of encounter that you might have. And cultural desire is at the end, but it's really at the beginning too. And that cultural desire is the desire to become more culturally competent and to have cultural encounters and to become more knowledgeable and all this. Cultural desire is what drives this whole effort of becoming culturally competent. So your awareness, cultural awareness, there are several stages. The first stage, the beginning stage, is unconscious incompetence, and we all start out there. There's no shame in being unconscious incompetent. That's where we all start at some point in time, and then we move on. But that's the person that has no awareness of other cultures or of culture, and they don't even know that they don't know. And then the next thing, you become aware that there are other cultures, but you're just totally at a loss for how to deal with them. And you become aware that, hey, there's these people from this other culture living here that I don't have a clue about how to interact with them without being offensive or without being misunderstood. And then from there, you start getting some knowledge, and then you become consciously competent. Maybe you get advice, maybe somebody in that culture maybe is a little bit more accessible and you can get some advice from them, like you say, well, maybe a colleague, maybe you have patients from another country and you happen to have a nurse from that country, so you start asking him or her for advice, and you become consciously competent. And finally, this knowledge becomes second nature to you, and then you're unconsciously competent. But then the next culture comes along or something, and you may be unconsciously competent with some cultures, and then with others you may be at other stages. Cultural skill is going to make it means that you're doing good cultural assessments, and you're also doing good culturally based physical assessments. So the difference between those two things is, when you're doing a cultural assessment, then you're assessing people's worldview, their family patterns, what their values, and that kind of thing. But a culturally based physical assessment means you're taking their culture into account when you're doing the rest of the healthcare assessment. And so your physical assessment is also culturally based, just taking into account their culture in order to get the maximum amount of cooperation and avoid misunderstandings and all that. And another aspect of cultural skill is that it enables you to make accurate interpretations. Like, for example, if you say, if I ask you, how are you doing today? You'll probably say, fine. Oh, I'm fine. And if somebody from a different culture, if a nurse from a different culture maybe, that wasn't aware of our culture, came in and said, oh, how are you doing today? And you said, fine. And then she or he might start wondering, well, why are you even here in the hospital if you're doing fine, because we always just say fine. It's more or less a greeting when we say, how are you doing? But that person might interpret it as being that you were fine, and maybe you're actually in pain, or you're depressed, or you're stressed, or all kinds of things could be wrong. But you're not going to say that normally when somebody says, how are you doing? So that would be an example of a misinterpretation. But as you become more culturally skilled, your interpretations would be better. So next comes cultural knowledge. So that would include sound education on different worldviews, but you have to also be aware that some of those just because, say, your patient is from Saudi Arabia, does not necessarily mean that that person entirely subscribes to that worldview, because maybe that person has been influenced by other worldviews such as our worldview. And so you have this stereotyped idea that, oh, she's from Saudi Arabia, so she's not going to want me to do this, or she's going to want that. And you discover that, well, no, actually she does want this that we do, so that maybe you have to be aware that, that of those kind of issues. Another aspect of cultural knowledge: what does the person believe causes illness? And so here we can get really smug and superior, and we're these scientific Western people, and this poor patient here believes that her illness is caused because she disobeyed her parents, and that brought down God's curse on her, or her illness was because of evil spirits, or whatever the belief about the cause of illness is. But how many of us don't believe that a draft is going to cause a cold? You go out and expose to a draft, or you go from the warm house and you're real warm and you just suddenly get exposed to a cold, and then you'll catch the flu. Those are totally unscientific beliefs too, but how many of us don't believe that, or even tell our children that? Also, kind of goes along with this, what beliefs do people in the culture have about symptoms? And there are all kinds of, like there in Vietnamese culture, there's all kinds of beliefs about hot illnesses and cold illnesses. I don't understand it very well, but there are definitely beliefs about hot illnesses and cold illnesses. I'm still learning too. Even though I've worked in Arlington for a while, I don't understand the Vietnamese culture very well. That's something I still need to learn more about. Also, knowledge would involve what is appropriate interactions among people, like particularly people of different genders, people of different age groups, what is appropriate or not appropriate in the culture as far as that. And also biological variations. As we'll see, there are numerous amounts of biological variations between different ethnicities and cultures and races. So cultural encounters, we can have face-to-face encounters, and the encounters, as we mentioned, you may have these encounters. Cultural encounter may occur just in the hospital, but particularly if you're interested in learning, you may seek out encounters outside the hospital, such as, for example, suppose you have started getting some patients from Middle Eastern patients. They're from, Muslim countries, and you become interested in, well, I wonder what makes these people tick. I want to learn more. And maybe the local mosque has an open house day and invites visitors, and you decide, well, I think I'm going to go to that and learn some more about it. Or maybe you're not willing to go that far, but maybe you notice that there is a Middle Eastern halal supermarket, and you decide to go there and see some of the foods that your patients are eating, and you befriend the storekeeper and start talking to him. So those would be different types of encounters you might have and different contexts as well. Maybe after you've done that, maybe an artist is coming to town from one of the countries you're interested in, and so you decide to go to the concert or something, or to the gallery, art gallery, and see that. And as we said before, cultural desire is kind of at the end of this whole model, but it's also the beginning of it. It's the motivation for the whole enterprise of becoming culturally competent, is cultural desire. So, purposes of the assessment, you want to, some of the important things you want to accomplish when you're doing a cultural assessment. You want to find out what the person's usual health type behaviors or illness behaviors are like. Like, find out, okay, well, tell me about when you've been sick before, and what did you do about that, and how did it work, and so, and what do you do to try and maintain your health? Those kind of questions. And you want to compare and contrast the beliefs to standard Western care. Now, you will probably find very few people in the world nowadays that totally reject standard Western care. There might be a few here and there, but most people are going to have some sort of relationship to standard Western care because it's been so successful. I mean, we do have in the scientific method, we have a very effective way of finding. We may not have found absolute truth by any means, but our science has found very effective means of treating problems. But a lot of people, and even us, even those of us who are participating in active, we're working in this healthcare system, we're not totally scientific in our beliefs by any means. If you just start asking nurses or even physicians about different things, like when they have their scientist hat on, why then they're all about, perhaps scientifically proven causes and things like that, but in their personal life they're probably eating that chicken soup to prevent illness, or they're taking vitamin C to prevent colds, or they're doing all kinds of things that are not scientifically validated. So it's easy for us to be judgmental with our patients and how can he believe that? That's such a silly belief, and science has shown, and all this, but we certainly have a lot of unscientific beliefs ourselves. But so anyway, off my soapbox, you want to compare and contrast the person's belief with standard Western care, and you also compare and contrast with those others of a similar background. And that's where I was saying that, say you have a woman who was born in Saudi Arabia, and that's all you know about her, and so you go in thinking, oh well, she's not going to want to have any male nurses, and she's going to want to cover her hair whenever any strange males are present, and she's going to want to ask her husband to make any decisions, and you have all these things, and then you go meet her and she's nothing like that at all. So it's important to compare beliefs of the patient with those of others of similar background. And then also finally to assess for diseases that are prevalent in that cultural group. And that is going to possibly take some research on your part, because there's some things that we, that are kind of widely known. Like most of us would know that African Americans have a higher rate of hypertension or of sickle cell disease, those things. But we may not know that Japanese people of Japanese origin have a higher rate of stomach cancer. So it may take a little bit of research, because there's hundreds and hundreds of facts about different disease prevalences based on cultural group. Some of the areas where cultures will vary, values for one thing, values, some may place a very high value on health, some may not place such a high value. Some may place a very high value on economic success, others may not place such a high value on that. Some may place a high value on family harmony and others may not. So there's all kinds of different values that are going to be different according to culture. Beliefs about human nature. Well, we probably would like to think we believe that human nature is basically good, but there are certain elements of our culture that are really, do we truly believe that? I mean, if we believed that human nature was basically good, maybe we would be more, we're very skeptical, for example, about somebody that's been to prison that and they say, well, I paid my debt and now I learned my lesson and I paid my debt, and we're looking at them like, yeah, maybe so, but I'm not letting you anywhere near the cash box. So we may, but yeah, some cultures believe that human nature is evil, the heart of man is wicked from the core, and other cultures believe that human nature is basically good, and there are all kinds of different beliefs about human nature. Beliefs about the relationship of humans with nature. Like I said, in our culture we tend to think of nature as not alive. I mean, maybe certain aspects, the animals and plants are alive, but it's separate from us. We're not a part of it. We don't see ourselves much as a part of it. It's something we should conquer and use to our exploit, use to our own advantage, and who cares about the consequences? Because somebody else will have to pay those consequences. Other cultures may see nature as being in a very close and intimate relationship with us. Also, beliefs about the purpose of life. Is the purpose of life to have the maximum amount of pleasure? Is it to work? Freud said to work and to love. That's the purpose of life, to work and to love. Or is the purpose of life to be in harmony with the world, or to, there are many things that might be the purpose of life. Beliefs about health, illness, and healing beliefs. That sounds a lot like nursing theory, doesn't it? And nursing theory addresses nursing, health, the human person, and then the environment. So, and that sounds a lot like nursing theory. Beliefs about the causes of disease, and then people may admit that, say, okay, the influenza is caused by influenza virus, but they may believe that you got that influenza virus because you didn't care for yourself, or you got that influenza virus because someone was out to get you, or you got that because you sinned and it's a punishment. So they may, you may have like the cause of it was the influenza virus, but behind that, if you wouldn't have been such a big sinner, you wouldn't have got the influenza virus. Or if you took better care of yourself, you wouldn't have got it, or whatever. uh, Also, who is a healer? Is a doctor a healer? Is the traditional faith healer person a minister of some kind of healer? Who is a healer, and what kind of things bring about healing? And we have to be a little humble there, because a lot of that, and for all of our scientific knowledge, we can't really say what brings about healing. Uh, Much of what we do in medicine is just kind of trying to buy some time for nature, for the patient to heal herself or himself. A lot of we just kind of give support in many cases. For many diseases, we just give support while the body heals itself. Some beliefs may affect whether or not you approach a healthcare provider or not, or how quickly you approach the healthcare provider. And some of this is quite beyond your control, as far as like occupation and income. I mean, if you don't have health insurance, and you live far from a county hospital, you may be out of luck. The hospital ER has to take you, but you may be reluctant to approach them, particularly if you went last month and they yelled at you because you hadn't paid your bills or something. So yeah, that may not be, and then when you do go, why didn't you come sooner? And you're thinking, oh, if only you knew. But anyway, things that may affect your approaching the provider, anything from ethnicity, generational status. Maybe if the provider is very old and you're very young, even if you're in the same culture, you may be reluctant to go. Or likewise, if the provider's very young and you're very old, yeah, it may make you reluctant to go. Your own educational level too, that may have an impact. Your religion, maybe you belong to a religion where the preacher says, oh, if you had faith you would not be sick, so going to a healthcare provider is a sign of weak faith. Your own previous experiences, good or bad. And beliefs about time and space, like, well, the time, well, this illness has only just begun. I think I'll see if it solves itself rather than going to the hospital or something. Or your beliefs about space, the hospital's so far away I can't get there. And then communication needs, preferences can also affect how you approach the provider too. So time, space, and communication. Some cultures really value the past, where they're always talking about ancestors or great things that happened in the past or things like that. And other cultures may really value the future, and others may place a high value on the present. I mean, obviously, all cultures make room for all three, for past, present, and future, but how they value them, what is considered of most value, is going to be different from one culture to another. Also space, as far as how close you stand to people you're talking with, or how close do you use touch or not. Those kind of things are going to be very culturally different, and so if you aren't aware of those differences, there can be miscommunication. People are going to think, well, oh, she's really cold and distant, or oh, she's moving in on my space, she's just really aggressive. eye contact also. We tend to value looking people in the eye, where sometimes that's considered rude or aggressive. And then just general body language. Sometimes the body language in one culture is not going to be come across the same way in another culture. And use of silence also will be different. Some of the factors that affect illness and health, for one thing, there's the biomedical variations where we have different culture, people in different cultures will have different genes, and based on genetics they may be susceptible to different diseases. But also lifestyle will also play a role too. Diet, the diet is different, and family roles may be different. Workforce issues, as far as we know that there's a lot of occupational hazards, and based on what kind of work is done by whom, that may impact your risks. And also high risk behaviors. Is alcohol forbidden, or is binge drinking encouraged? Is smoking a big thing in a culture or not, or or is smoking discouraged? All kinds of things like that can affect illness and health. Another issue might be pregnancy and childbirth practices. Where do you go to give birth, and who do you have helping you? Who's present for childbirth? And then death rituals, uh, religious beliefs or rules, religious rules, which you may or may not break depending on the circumstances. Uh, and then what healthcare practices are encouraged in a culture, and who are the healthcare practitioners in that culture, and then the environment where the people actually live. Some of the biological differences, there's a lot of them mentioned in the book, and I'm not going to go through all of them. One interesting thing is eccrine glands, and these are the ones that are scattered throughout the body, and they produce sweat. They will function greater among people born in the tropics, even after those people have left the tropics and live somewhere else, but they'll have lower chloride in their sweat. So the people from the tropics will tend to have sweat more, but they'll be secreting, they won't be secreting as much chloride in the sweat. Apocrine glands, these are the ones that cause body odor, and these they're fewer in among Native Americans, Asians, and children of all races or ethnicities before puberty will have fewer apocrine glands, which is why you think of a man that's a working man that sweats and really stinks, and then a child that sweats equally will not smell, you will not have as much body odor. But also Native Americans and Asians will have less body odor as a result as well. There's also dry and wet earwax, two different types of earwax. Interestingly, the dry earwax, which the dry earwax is more common among Asians, and the wet earwax is more common among Caucasians and African Americans. But the dry earwax also correlates with lower incidence of breast cancer, and so even within an ethnicity, like if you happen to have the dry earwax and you're Caucasian, your incidence of breast cancer is lower. And then African blacks have lower incidences of varicose veins. I don't know about African Americans, if the incidence of varicose veins is lower or not. Then most poor children from poorer socioeconomic status tend to develop earlier. I don't know what the reason for that is, but the one implication that has is that if you're doing developmental screening, and if you have a child from a poorer socioeconomic background and they're kind of lagging just a little bit, you would be more concerned about that child than about a child from a wealthier socioeconomic background that's lagging just a little bit. The one that, like, if they're lagging just a little bit, and you're probably saying, well, they're probably okay, they'll catch up. But the poorer, the result is more extreme in the poorer child there. So, because they tend to have earlier developmental, they pass the developmental milestones earlier. Another difference is lactose intolerance. And European and some Middle Eastern people are among the few that have high rates of being lactose tolerant, where most of the world, like in Asia and Africa and places like in the Americas, the Native Americans, there's a lot of people that are lactose intolerant after they reach adulthood. It's not so common among Europeans, but there are, of course, some Europeans as well that are lactose intolerant, but that's one difference. And then the sickle cell trait is concentrated in areas where you have malaria, which is mainly Africa and areas around the Mediterranean. It is protective against malaria, and that's why it has survived. But when you have two people that are heterozygous for the sickle cell trait, some of their offspring will have, like, they'll be homozygous for sickle cell disease, and even sickle cell trait will lead to some sickling. But if you have somebody that ends up being homozygous with both of the recessive genes for the sickle cell, why then that person would be extremely ill, probably would not survive very long. Maybe they would survive long enough to have children too, but and pass it on. But the people with just the trait will have sickling, and they'll have crises from time to time, but it's protective against malaria. They can live for a fairly long life, and so therefore the disease, if they're living in an environment where malaria exists, it can actually provide an advantage, but otherwise it provides mainly disease. There's also differences in drug metabolism among different races and ethnicities. And for example, African Americans respond differently to some of the hypertensive medications, so that some of the medication choices may be based on race, the medication choices that you use for treating hypertension, for example. And there are a number of other biological variations mentioned in the text, but I'm not going to go through the rest of them. I'll leave that for you, that when you have specific issues that you want to look at, you can look them up.